السلام عليكم ورحمة الله وبركاته. ألتقي بكم من جديد أعزائي طلبة المرحلة الخامسة في طب الأسنان لإكمال الجزء الثاني من محاضرتنا بعنوان Autoimmune Diseases ضمن سلسلة محاضرات مادة طب الفم. تلقى عليكم من قبل التدريسية مدرس دكتورة وداد فرحان جابر، تدريسية في كلية طب الأسنان جامعة الانبار. نبدأ على بركة الله. تكلمنا في الجزء الأول من المحاضرة على الأوتوإميون ديزيز، عرفناها وتكلمنا عن الديزيز أول مرض أخذنا السيستميك لوبس إريثيماتوسس اللي قلنا هو archetypical example for the autoimmune disease. اليوم ناخذ the other disease اللي هو scleroderma. So scleroderma refer to a group of clinical disorders characterized by thickening and fibrosis of the skin. The generalized form, systemic sclerosis, is a multi-system connective tissue disease in which the fibrosis extend to the internal organs, including the heart, lungs, kidney, and gastrointestinal tract. Women being affected 3 to 4 times as frequently as men. There are two main forms, systemic sclerosis and localized scleroderma. Systemic sclerosis is further divided into limited cutaneous scleroderma and diffuse cutaneous scleroderma. Patients with limited scleroderma often have a long history of raynaud's phenomena before the appearance of other symptoms. Skin thickening limited to hands and problems with digital ulcers are esophageal dysmotility So for diffuse scleroderma, the patients of diffuse scleroderma often have arthritis, carpal tunnel syndrome, marked swelling of the hands and legs. They also characteristically develop widespread skin thickening, progressing from fingers to the trunk. Internal organ involvement including gastrointestinal and pulmonary fibrosis and potentially life-threatening cardiac and renal failure. Localized scleroderma refers to scleroderma primarily involving the skin with minimal systemic features. There are two major types of localized scleroderma: linear scleroderma and morphea. Linear scleroderma is characterized by a band of sclerotic induration and hyperpigmentation occurring on limb or side of the face. Regarding morphea, what is morphea? Morphea is characterized by small violaceous skin patches or large skin patches that indurate and lose hair and sweat gland function. This lady have morphea appear in the face, and as we said, the area violaceous appear as violaceous patch and the area loss hair and sweat gland. According to etiology and pathogenesis, the etiology of systemic sclerosis is unclear, but the pathogenesis is characterized by vascular damage and an accumulation of collagen and other extracellular matrix components at involved sites. Clinical manifestations. Patients with systemic sclerosis as opposed to limited scleroderma, typically have rapid skin thickening and visceral organ involvement. Raynaud's phenomena refers to severe form of the digital cyanosis, numbness, and blanching. Cutaneous manifestations include skin thickening of fingers and hands in almost all cases. The neck and the face are usually the next sites to be involved. Hyperpigmentation and telangiectasia also seen in these patients. These two pictures related to the same patients. Patient with scleroderma. Look at the skin lesion as we told before. Appear as telangiectasia, small spot in the face, multiple small spot in the face, and the picture of the hand appear with thickening of the skin, as we see in the picture, and hardening. Musculoskeletal manifestations, we recognize generalized arthralgia, morning stiffness, muscle weakness. Gastrointestinal manifestations, the patient may have esophageal motor dysfunction and gastroesophageal reflux disease, and the intestinal fibrosis result in malabsorption. Cardiac manifestations include ischemia, fibrotic and inflammatory lesions in the pericardium, myocardium, and cardiac conduction system. Pulmonary manifestation, the patient may have progressive interstitial lung disease, can lead to pulmonary arterial hypertension. For renal manifestations, patients may have renal crisis, scleroderma renal crisis. Oral manifestations, the lips become rigid and the oral aperture narrows considerably. Skin folds are lost around the mouth, giving a mask-like appearance to the face. The tongue can also become hard and rigid, making speaking and swallowing difficult. Involvement of the esophagus may cause dysphagia. Oral telangiectasia is equally prevalent in both limited and diffuse form of systemic sclerosis, and is most commonly observed in the hard palate and lips. When fibrosis involves the muscle of mastication, mandibular resorption can occur. Mandibular movement may be restricted by muscular fibrosis, and linear localized scleroderma may cause hemiatrophy of the face. Dental radiograph findings have been reported. Classic findings such as uniform thickening of the periodontal membrane, especially around the posterior teeth, are found in 10 to 37 of patients. This picture shows radiograph refers to patients with systemic sclerosis. We can notice the thickening of periodontal membrane, and the thickening is especially seen around in the periodontal membrane around the posterior teeth. Other characteristic radiographic findings include calcinosis of the soft tissues around the jaws. These or the areas of calcinosis will be detected by dental radiography and may be misinterpreted as a radiographic intrabony lesions. A thorough clinical examination will demonstrate that the calcification that present in the soft are just calcification in the soft tissue and not bony lesion. Medications may reduce salivary fluoride, or patients with scleroderma may have secondary Sjogren's syndrome. Xerostomia results in increased susceptibility to dental caries and candida infections. Manual dexterity is limited in scleroderma. Patients which decreases their ability to maintain good oral hygiene. Oral hygiene can be complicated further if opening is limited. Laboratory evaluation and diagnosis. Diagnostic criteria include skin thickening, pulmonary manifestation, Raynaud's syndrome, telangiectasia, and laboratory abnormalities which include anti-centromere, anti-oxoaminase A1 and anti-RNA polymerase 3 autoantibodies. For a treatment of patients with scleroderma, the treatment is usually depends on the extent and severity of skin and organ involvement and on the clinical stage of the disease. Immunomodulatory agents to control inflammation can be used for Raynaud's phenomena. Avoidance of cold exposure is crucial. In addition, calcium channel blockers are prescribed. Also, we have the drug called methotrexate and cyclophosphamide can be used for the treatment of the patient. For dental management, what we do for dental management of patients with scleroderma. The most common problem in dental treatment of systemic sclerosis patients is the physical limitation caused by narrowing the oral aperture and rigidity of the tongue. Customized toothbrush handles should be provided for patients who cannot grip an ordinary toothbrush, and the plaque control may improve with an electric toothbrush. When treating a patient with diffuse scleroderma, the extent of the heart, lung, or kidney involvement should be considered, and appropriate alterations should be made before, during, and after treatment. Patients with extensive resorption of the angle of the mandible are at risk for developing pathologic fractures from minor trauma, including dental extractions. The other disease is called rheumatoid arthritis. The other type of autoimmune disease is called rheumatoid arthritis. So what is rheumatoid arthritis? Rheumatoid arthritis is a disease characterized by symmetrical inflammatory arthritis of small and large joints. In contrast to degenerative joint disease, rheumatoid arthritis is a systemic disease with constitutional symptoms including fatigue, weight loss, morning stiffness, low-grade fevers, and anemia. The etiology of rheumatoid arthritis is unknown, but there is substantial evidence that it is a complex genetic disease. Subtypes of rheumatoid arthritis. We have two types: juvenile arthritis is a term describing any arthritis in children. The other type is juvenile idiopathic arthritis, includes those children with chronic arthritis. Symptoms of juvenile idiopathic arthritis include joint pain, swelling, tenderness, warmth, and stiffness for at least 6 weeks without another cause. Felty's syndrome. Felty's syndrome characterized by neutropenia, splenomegaly in conjunction with rheumatoid arthritis. So, Felty's syndrome, we have 3 features for this syndrome: neutropenia, splenomegaly, and rheumatoid arthritis. These patients have additional susceptibilities to bacterial infection if neutropenia is severe. Clinical manifestations of rheumatoid arthritis. Rheumatoid arthritis is a symmetric polyarthritis, often involving the proximal interphalangeal joints of the fingers and metacarpophalangeal joints of the hand. The wrists, elbow, knee, and ankle and also can be affected. So any joint in the body can be affected. Even the TMJ can be affected also. In some patients, all joints may be involved, including the TMJ and the cricoarytenoid joints of the larynx. Affected joints develop redness, swelling, and warmth, with eventual atrophy of the muscle around the involved area. Look at this picture of X-ray related to patient with rheumatoid arthritis. Disfiguring of the joint of the hand is clear, and ulnar deviation of the fingers is also clear in this X-ray. Oral manifestations. The treatment of rheumatoid arthritis can cause oral manifestations. The long-term use of methotrexate and other anti-rheumatic agents such as non-steroidal anti-inflammatory drugs can cause stomatitis with oral ulcerations. The increased dental and periodontal disease in the rheumatoid arthritis population may be related to the decreased ability to maintain proper oral hygiene because of limited manual dexterity. The TMJ is a synovial joint that can be affected by rheumatoid arthritis. When TMJ arthritis is symptomatic, patients may present with pain on palpation, limited opening, deviation of the mandible on opening, ankylosis of the joint, and or facial asymmetry. For the diagnosis of patient of rheumatoid arthritis, we depend on clinical criteria, and for each criteria we have a score. So we can classify these criteria into a joint involvement. We have 4 levels. The first, large joint, shoulders, elbow, hips, knee and ankles, give the score 0. 2. 10 large joints have a score 1. 1 to 3 small joints with or without large joints have 2. 4 to 10 small joint with or without large joint have 3 scores. More than 10 joints, at least 1 small joint, 5 score. For serology, at least 1 test result is needed for classification. Negative rheumatic factor and negative anti-central-related protein antibody give score 0. When low positive rheumatoid factor or low positive ACPA have score 2. High positive rheumatoid factor or high positive ACPA give score 3. For acute phase reactant, depending on C-reactive protein, at least one test result is needed for classification. When normal C-reactive protein and normal erythrocyte sedimentation rate, we have score 0. When abnormal C-reactive protein or abnormal ESR, we have score 1. The other step or the other point, important point in the clinical criteria for diagnosis of patients with rheumatoid arthritis is the duration of symptoms. And in this case we have 2 points regarding the duration of symptoms. If less than the duration of symptom, if the duration of symptom less than 6 weeks, we have score 0. And when the duration of symptoms equal or more than 6 weeks, so the score will be 1. The classification system is aimed at classifying newly presenting patients and is applied to those with at least one joint with synovitis. For the treatment, methotrexate often used as initial therapy for symmetric polyarthritis involving 3 or more joints. This drug reduces disease activity, joint erosions, and is associated with a significant long-term reduction in mortality. For dental management of patients with rheumatoid arthritis, many patients with rheumatoid arthritis will take non-steroidal anti-inflammatory drugs, which can cause gastric ulceration and affect kidney function. Patient who is taking aspirin, intramuscular doses of gall salt and D-benzyllamine should have a complete blood count and serum chemistry studies before dental treatment. Patients with cervical spine disease may have C1 to C2 subluxation and spinal cord compression. Hyperextension of the neck must be avoided. Prolonged morning stiffness is common in rheumatoid arthritis, so later morning appointment may be best for the patients. then عادة يكونون عندهم morning stiffness، فيفضل انه نعطيهم مواعيد إذا كان عندهم مشاكل بأسنانهم يحتاجون أي شغلة تخص الأورال كافيتي يعني تريتمنت، إنه مواعيد متأخرة. Patients with Sjogren's syndrome may require additional instruction in personal oral care and instruction on diet and dietary modifications. Patient has Felty syndrome, a complete blood count should be obtained before treatment, as these patients may have neutropenia and thrombocytopenia. بهذا القدر نكون أعزائي الطلبة أكملنا محاضرتنا اللي كانت بعنوان Autoimmune disease. أتمنى أن استفدتم منها والمعلومات اللي ألقيتها وطرحتها بالمحاضرة. على أمل اللقاء بكم إن شاء الله في محاضرة أخرى. أشكركم، أشكر إصراركم، والسلام عليكم ورحمة الله وبركاته.